going to talk about congestive nephropathy. In my opinion, it's a really, really interesting topic, and it's a new concept in probably an old situation, but a new concept in for all the specialties, not only in critical care, but probably in cardiology, nephrology, and for sure, I think it's really interesting. This is my disclosures, and this is our daily history. We go to the emergency room for a 71 years old patient with a lot of comorbidities, heart failure, chronic kidney disease, diabetes. And for example, this patient was admitted with dyspnea, also with orthopnea, with bilateral edema. Initially, the patient was hemodynamically stable with a lower saturation, and we cannot see correctly the jugular ingurgitation because it's not easy to explore. And also we can, with the auscultation, we can listen diminished vesicular murmur at the right base and some crackles. Also, the patient have edema. And we can observe the serum creatinine. We start with the furosemide because the creatinine is 3. And in the next 24 hours, the creatinine increase, and we cannot reach a complete descongestion with this amount of furosemide. For this reason, we increase the amount of furosemide. And in the next 48 hours, the patient cannot we cannot descongest the patient, but we can observe a hypotension, a lower urinary sodium, and we start to be afraid because we do with this patient, the creatinine is raising, we cannot descongest the patient, and we observe an increase in the serum creatinine. And probably in all the hospitals entire world, a big majority of physicians start the push and flush, a little amount of fluids and a little amount of furosemide in order to try to improve the kidney function. But the patient do not improve. The patient reduce the urinary output, increase the body weight, and increase the sink of congestion. And finally, we start the ultrafiltration, the extracorporeal ultrafiltration. This is the history of our patient in all our hospitals entire the world, because we wide the descongestion with one biomarker that is not good, the serum creatinine. And in the other hand, in the same patient, we start the insonation after after the lung ultrasound. We start with the venous congestion assessment with the Vexus, as Professor Hatteman talked in the past. And we start with the evaluation of the inferior vena cava. In this case, the inferior vena cava is more than 2 centimeters without collapsibility. Then we move to the hepatic vein, and we observe an ease reverse pattern. We observe also a pulsatility pattern in the portal vein, and also we can observe this monophasic flow in the intrarenal venous flow. But probably about this slide, I want to show you the time in we perform this evaluation. We start at this time, and we spend for the entire Vexus insonation no more than 10 minutes. Then probably it's not difficult to evaluate our patients with the echograph, with the ultrasound, and we have a lot of information because in this patient, when we observe this pattern of congestion, we don't wait more than 24 hours or more than 48 hours to start the ultrafiltration, because we know that the patients have a severe grade of congestion or venous congestion, and it's not matter the creatinine. The important is the congestion. If the patient is still congestive, probably we need to move for another treatment or therapy to reduce the congestion. And we're going to talk about now the congestive nephropathy. I'm going to show you how we can build the diagnosis. I'm going to try to explain how the ultrasound help to widen the descongestion, and we're going to finish with the take-home message. My first question is, do we really need new metrics to access the congestion, or probably we have enough with the traditional physical examination, serum creatinine, body weight to evaluate the congestion? The problem is congestion is common in the patient. For example, in the heart failure scenario, more than 80% of the patients that consult by heart failure have any grade of congestion. But I think that it's more important to understand that at least 20% of the patients are discharged with congestion. They come for heart failure, but they go at the home with congestion. We don't not do the things well in these kind of patients. And for example, in the ADER register, almost 40% of the patient reach or increase the body weight after the discharge. Then probably this is not good because our patient is still congestive after the discharge. And the result of this situation is the highest readmission rate among all medical conditions in heart failure patients, 23% at the first month and 40% at the 3 months. Then for this reason, try to understand better the congestion. It's really, really important. But it's really important to know that the congestion is associated with a higher mortality, not only in heart failure, also in patients with in the critical setting patients. We know that when the fluid overload increase, the mortality also increase in the critical setting. And we know that the congestion has systemic consequence. It's not only the crackles or the rails or the jugular ingurgitation. It's not only the edema. We know that congestion have an important impact in the function of different systems like the respiratory system, the cardiovascular system, and also in the kidney, the congestion is important. And this is really interesting because now we know that the main mechanism for the kidney damage is not the hypoperfusion mechanism. We know that we know from the ESCAPE trial that the variation in kidney biomarkers as glomerular filtration rate or the urea or the creatinine is not correlated with low cardiac output. That means that the hypoperfusion mechanism is not the main mechanism of kidney damage in patients, for example, in heart failure. But on the other hand, we know that the increase in the right atrial pressure or the increase in the central venous pressure is associated with an increase in the serum creatinine. That means that the main mechanism of kidney damage in heart failure is the increase in the right atrial pressure and the increase in the central venous pressure. And this is because we know that the kidney perfusion pressure is the difference between the main atrial pressure and the central venous pressure. If the central venous pressure increase, the kidney perfusion pressure decrease. And this is really interesting because the kidney start all the autoregulation mechanisms in order to increase the filtration fraction and in order to maintain the glomerular filtration rate stable. But this is not good because there are an increase in the filtration of sodium, chlorine, and water. And this is the main stimulus for the proximal tube to increase the sodium, chlorine, and water reabsorption and increase the interstitial hydrostatic pressure. And we know that the kidney is an encapsulate organ that cannot be increased the interstitium because the capsule cannot don't help to this increase in the weight of the kidney. And this is really important because the cardiologists call the renal compression or the kidney tamponade. That means that the kidney cannot be more dilated or cannot expand the interstitium for the capsule. And this is the main reason because our patients with heart failure decreased or worsening the kidney function. The next biomarker that we have is the creatinine. Creatinine, we know that have several limitations. Creatinine is always late in the diagnosis of AKI. And we cannot stop, or we cannot take decisions only for the serum creatinine, because creatinine is always late to the damage. And in heart failure, there are something really interesting: the elevation of the serum creatinine, but also the decrease of the serum creatinine is associated with bad outcomes. And for example, there are not correlation in patients with a descongestive therapy. There are not correlation between the increase of the serum creatinine and the increase of the biomarkers of tubular damage. That means that not always the increase of the serum creatinine in patients with heart failure during the descongestive therapy is bad. Probably some cases is good and is necessary, because this increase in the serum creatinine is equal to an improve of the descongestion. And always our objective is perform a wonderful descongestion of our patients. But also we have now the point-of-care ultrasonography. The point-of-care ultrasonography is a wonderful strategy in order to improve the sensitivity of the physical examination. As Avilash told us, we know that the sensitivity of the physical examination to detect the congestion is not good, have a poor sensitivity, but when we include the point-of-care ultrasonography, probably we can increase this capacity to detect the congestion in different settings, in the lung or in the venous territory system. We wrote with this paper with Avilash Koratala and Eduardo Argaiz about the importance of the point-of-care ultrasonography in the evaluation of patients with cardiorenal syndrome. And now we know that when the right atrial pressure increase and the central venous pressure increase, there are a backward mechanisms that transmit this pulse, this rise in the right atrial pressure to the intrarenal venous flow. Normally, the intrarenal venous flow is continuous, as you can see below of the baseline. Yes, here in this part we can observe the arterial flow, but here is the venous flow. But when the right atrial pressure increase, we can observe a change in this pattern to a different pattern, like a biphasic pattern or a monophasic pattern. And this is the first step for the congestive nephropathy. In fact, we know that the discontinuous pattern of the intrarenal venous flow is associated with high central venous pressure using the right atrial pressure or the diameter of the inferior vena cava. But also we know that the discontinuation pattern of the intrarenal venous flow is associated with the elevation of the serum creatinine. 63% of the patient with a discontinuation pattern in the intrarenal venous flow elevated more than 0.3 milligrams deciliter the creatinine. And when we increase the cutoff of the serum creatinine to 0.5, 72% of the patient with a discontinuous pattern increase the serum creatinine. But and this is really interesting, because we know that the progression of the intrarenal venous flow is dynamic during the descongestive therapy, and we can observe that those patients with a discontinuous pattern are move to a continuous pattern during the descongestion therapy. In fact, we know that those patients with that change from a discontinuous pattern to a continuous pattern have a better prognosis than those patients that are still congestive or still with a discontinuous pattern in the intrarenal venous flow. And also we know that those patients with a discontinuous pattern and an increase in the serum creatinine have had bad outcomes, more admissions for heart failure, more probability to death, and are associated with bad outcomes. But the patients in heart failure, not only it's associated with bad outcomes in terms of hospitalization or mortality. We know that also those patients with an intrarenal venous flow discontinuous discontinuous pattern in the intrarenal venous flow have a higher probability to require kidney replacement therapies. Then this pattern of intrarenal venous flow is talking about not only outcomes in terms of mortality or admission is also associated with bad outcomes in terms of treatment. And the next biomarker that I think is really interesting to diagnose the congestive nephropathy is the albuminuria. Remember that the albumin is reabsorbed by the proximal tube, and when the proximal tube increase the reabsorption of sodium, chlorine, and water, also increase the reabsorption of albumin. But when the tubular function is still bad, this capacity to reabsorb the albumin is lost, and we have more albuminuria in this kind of patient. In fact, we know from this study of Eva Borsma that almost 30% of the patients with heart failure, with acute heart failure, have a higher grade of albuminuria, and this situation is associated with a high inferior vena cava, high diameter of inferior vena cava, with high NT-proBNP and high CA 125 as biomarker of congestion. And this situation is associated with a higher mortality and higher heart failure hospitalization. And this is really important because we move from the old pre-renal acute renal failure concept to a new concept that is the cardiorenal syndrome, the venous renal syndrome, and the pseudo-worse renal function. In this case, POCUS is really interesting to understand this situation. But also, I think that it's really important the use of the point-of-care ultrasonography for detect or for predict the diuretic resistance. We know that the most important situation during this congestive therapy is the decrease of the natriuresis. In the first 24 hours, there are a reduce in the natriuresis, and this situation is not good because that means that all the tubules are reabsorb all the sodium that they can. In fact, it's more important to have a negative sodium balance a negative sodium balance in patients with a diuretic therapy. Not only the diuretic response is important, also the natriuretic response is really, really important. In fact, the idea of all these new drugs in the treatment of the congestion is try to increase the sodium elimination by urine. And also we have the furosemide stress test for predict the diuretic resistance or the response of the tubule to the diuretics. But also we have this good biomarker, the urinary sodium, to predict the diuretic resistance. But I want to focus your attention in the importance of the point-of-care ultrasonography. If you have a patient with a higher creatinine and with a discontinuous pattern in the intrarenal venous flow, probably you during this congestive therapy with diuretics, for example, this group of patients have a low diuretic efficiency. Then for this reason, it's important if the patient is still with a discontinuous pattern, despite the diuretic treatment, probably the response of this diuretic is not good and your patient have any kind of diuretic resistance. In fact, we observe in this study that we published with Faik Hussein that those patients with discontinuous pattern in the intrarenal venous flow have a higher probability to require kidney replacement therapy. Then we are talking we are not only perform a diagnostics of congestive nephropathy, also we are talking about bad outcomes in patients that is still with a discontinuous pattern during the diuretic therapy. But in my opinion, we need to combine all these metrics for the inferior vena cava, the hepatic vein Doppler, the portal vein Doppler, and the intrarenal venous flow with other biomarkers are the serum chlorine, because we can widen the therapy, and also we can perform a more individualized and personalized treatment with patients with heart failure. We published this randomized clinical trial in patients with acute heart failure with cardiorenal syndrome type 1, in which we divide the patients, widening the descongestion with the Bexus score and with the usual approach. And we observe that those patients in which the descongestion is wide with the Bexus score, though we reach a better descongestion in a lower period of time than in the usual approach, with an important decrease in the congestion biomarkers of the BNP without a damage in the kidney function. That this is really, really, really important. But also we published this algorithm in order to show the importance to use the point-of-care ultrasonography, not only the evaluation of the intrarenal venous flow, also including the lung ultrasound. And as Professor Hattem told us, the important to include the echocardiography of the focused cardiac ultrasound in order to understand if the patient is still congestive or have a situation of a low stroke volume or low cardiac output. We published recently with Avilash and other nephrology colleagues this paper because we think that it's important the training of our nephrologists in the use of the point-of-care ultrasonography. Probably is not only to listen different talks, or it's important to take the ultrasound machines and perform multiple evaluation to our patients to learn the importance of the point-of-care ultrasonography. And it's really important to apply this concept in the real life with the real patient, not only with anatomical models. In our hospital, we start a fellow program in point-of-care ultrasonography in order to training different nephrologists around the world in this important technique. And finally, my conclusions, it's important to know that in the worsening kidney function in cardiorenal syndrome is growing, but I think that we need to move to different scenarios as critical care, in nephrology, in oncology, and different settings. It's important to know that there are different important limitations of the serum creatinine in the diagnosis, and for this reason, it's necessary to have more metrics to evaluate the congestion. It's necessary to unify the concept of worsening renal function and the pseudo worsening renal function and AKI in the context of cardiorenal syndrome. The early identification of diuretic-resistant patient is essential because we know that too late is not too good. Congestive nephropathy once again position us as a specialist in control the homeostasis. And I think that let's not be permissive with congestion. Congestion is not good in any scenario. And thank you so much. This is